Good afternoon. Beth is your patient information. May I
Harry,
help you?
room 616.
Okay, he's in room 588. Take the blue elevators there to the 5th floor. When you get off, take a left.
Maybe just to adjust, to get his respiratory settings changed in such a way that he doesn't look like he's breathing so hard. I think it's a little bit disconcerting for the family to come in here and see him struggling like that.
Well,
So, I mean, it's just an idea, just a passing idea.
what we should try is, if we think he stands any chance of being extubated,
Right.
I'm going to call his family and tell him that, this is a situation. I've spoken to them before. They know the situation. Tell them that he seems as though he's breathing on his own, and we should
Gary?
make an attempt, take out the tube, leave it in God's hands, see what happens.
Well, okay, I don't know where you're at with that. He has a heart rate of 140. He's got dependent crackles, diffuse wheezing. He may not fly. So make sure that you and the family are quite clear about whether this is sort of, we're going to stop ventilating him once and for all, or we're going to try it and just see, But make sure you've decided before exactly what you're doing.
I want you to understand the situation and sort of where we stand. I think what seems to make the most sense to me at this point is that since his brain, he's never going to wake up, that it wouldn't make sense to continue on in this state. Now we could try stopping the ventilator, and if he breathes, then he breathes, and if he doesn't, then it's in God's hands now. Now, but not knowing really how you felt on this, I wanted to call and find out, and we hadn't actually spoken in a while, so.
I know.
He is, so he may breathe on his own, and that's certainly a possibility, but it's hard for us to actually know that for sure, and I'm saying we take it out, we may find out that he doesn't, in which case he would, if it were somebody who were alive and well, we would put the tube back in. But I think, given all the situation, which you seem to understand, it wouldn't make much sense to put the tube back in because his brain is gone. I know this is a very difficult topic, and for you.
You know what the date is? What month is it? Is it winter time?
Could be anything. Okay, you got the ready? I'm going to slide you over. Ready? 1, 2, 3.
How you feeling this morning? What's that? Can you look over here? Look at my fingers. Can you follow my fingers?
I'll let you do your work, too.
I'm going to get your weight, Mr. Toomey, on a special scale. Just lifting you up in the air.
86.2.
Okay.
I mean, I think it's important that everybody feel comfortable with what we're doing. I personally think that his antibiotics are, you know, it's like a pea shooter against an atomic bomb. I mean, the guy is not, I mean, if you look at the natural history of what's happened here and what his prognosis is and what we know about, you know, terminal lung cancer, I mean, there's not anything any of us is going to be able to do. And whether you give him the antibiotics or not, I think is sort of more how you feel personally about it. I guess the issue that's going to become, you know, a major issue is that everybody feel comfortable with sort of withdrawing his care. I certainly do. I mean, I think that on Friday night, you know, I've never thought that when the guy arrived here that he had a chance of pulling through. But I do think it's very important for the family to give them, you know, the feeling that we're doing everything that we can till the point that they come to the realization that, I mean, there are a lot of unresolved issues here. He never dealt with his feelings with his younger daughter. A lot of anger on both of their parts, evidently. And both, you know, they've been married for 34 years. I mean, you know, a lot of other, and I think they all, you know, didn't have a chance to say goodbye to him. And that was the thing that was really irking them. I think they sort of knew intellectually that he wasn't going to make it, but emotionally on Friday they were just not prepared to accept that. And I think now they've evolved to a different stage in their own feelings. And I mean, I think that we've got to sort of take that into account. But, you know, always in a situation like this, there are 4 or 5 different groups of people here. I mean, there's, you know, the nurses knew from the moment he walked in the door that he wasn't going to make it. And I think that the family was a bit angry that they were getting that message from the nurses. I mean, I sort of knew that too, but I didn't give them the same message. I sort of said, yes, you know, we're going to do all this stuff. But everybody's got to feel comfortable that we're, you know, before we sort of embark on a course of action here, that we're doing the right thing. I mean, nobody likes to lose. I mean, but this is not something that we have a lot of control over. But I mean, I think if people feel differently about it, now's the time to say so, because I think that I'm going to have to talk to the family sometime today about, you know, withdrawing support. And my own personal feeling is that I don't think that we have, you know, it's just a question of his dying today or dying 3 days from now.
You know, I mean, the acute deterioration on Saturday is really what turned the family around, and since then they've really, sounds like they've just really evolved in their feelings and their wishes.
But I was really asking the question for everybody here. You know.
Well, it's my feeling before he had this deterioration on Saturday that if he were to stop bleeding long enough, presumably he'd eventually mobilize that blood, re-expand, and potentially come off the vent. In which case, if he had XRT, and if he didn't re-bleed, he could have a couple of months. But now we've shown him that he's just bleeding again, back to where he was before, that he's not going to stand a chance at ever getting off the vent.
Yeah, I mean, you know, somebody who treats a lot of lung cancer, I don't think there's anything in the medical literature that would justify the optimism of the radiation therapists in terms of what they said, even on Friday.
Well, the oncologist, too.
Well, actually,
the oncologist. I mean, Annette said, well, he could have gotten 3 days of XRT by now, but now it's too late. And I said, that wouldn't have made any difference. He bled Saturday morning.
Okay.
Hey, Mr. Gavin, I have not reported any chest pain yesterday. His CPKs from the previous days ruled out. His VEA was at baseline yesterday. Over the course of the day, he remained on the drips he was on yesterday, renal range with dopamine, dobutamine, and his nitroprusside increased over the course of the day. It's tolerated to keep his blood pressure above 80. With doing that and 1 dose of diuretics in the morning,
All right, it's charged.
Unhook her from the EKG.
Just turn it on. I got it.
All right, let's shock defibrillate with 2 minutes.
Wait a second. All right. Clear.
Okay, quick one.
No problem.
CPR.
Wait, Tom?
Wait, I need this.
Is there something disconnected? Yes.
Yeah, but you can just not. Okay, you want to...
CPR for just a second, please. It looks like ACPR. All right, that's it.
Anybody has any more ideas?
But he has told us that he does not want to live on the tube.
How are we doing? Right.
Okay, I mean, he's made clear to me, he's made clear to you, that's been his major concern all along. So that if at some point you're saying, we can't wean him, then I think that per se is, to me at least, that per se is an indication to stop, to DC the tube. What he is saying, what he has indeed said is, I do not want to live on the tube. I don't want the tube if I can't get off the tube. Right. And so if you hit that point, then yes, you DC it.
They got in touch with her son, who insisted that everything be done. So they looked for everything but, everything, sepsis and a ruptured viscus, to explain her acidosis, hypotension, and decreasing crit. And it became clear as she became recurrently hypotensive with this distending abdomen that this was a ruptured aneurysm. The surgeons...
As far as I know, that's not a medical disease.
The surgeons evaluated her, and Mark Lancer's note said, a short, H&P impression, ruptured aneurysm operation is futile with 100% mortality. I have spoken with son in charge and explained the situation, and he suggested comfort measures. Mark Lancer, the surgical attending, comfort measures and no resuscitative efforts. The son insisted that everything be done. And the son, I think, is now flying here. From, I don't know where he lives, but he's apparently in a plane. I think that there are two more. I think there are two daughters, but they haven't been contacted. And so the EW nurses felt too uncomfortable having her downstairs. She's in the midst of becoming hypotensive and distending abdomen. She got intubated, which is why she has to be here, and she was put on lots of depressors. Now is on Levo and Neo.
Sounds like we're doing everything we can do.
So I said, why does she even have to come to the MICU? But we won't even get into that.
That's not worth...
No, it isn't.
That's fine. I think it's, because, one of the reasons for having her here is that we deal with this better than anybody else.
Well, now, see, the big issue was because the nurses felt that when, she dies, she has to be coded. Okay. Because the son insists that everything be done. And so they were preparing to do a code on this poor woman.
Yeah. I don't...
Which I don't know.
I guess the question is, there are lots of definitions of everything.
She's also gotten 4 units of blood. And I assume, bicarb and stuff. This looks like her gases got a little better. Yeah. Crit seemed to stabilize.
She hasn't had a gas since she was intubated.
She had one a little bit later, but the bicarb's on her SMA7. There's some bicarb that's getting better. I guess I don't see the point in doing any of that, because I agree this is a surgical disease, and if they're not going to do surgery, I don't see the point of prolonging it.
What's average age check the son?
Yeah, I think that, go ahead and take a quick look at her, and I don't know, the sort of what's happened with these, the DNR rules and everything is, over the last 5 years really makes, puts you in a difficult situation. I think that I would feel very comfortable in terms of everything being everything that we've done already.
Yeah.
Is she awake now?
She's awake a little bit now. She has a baseline dementia, so I don't know what her understanding is. But she is a little bit awake right now.
What's the son's understanding?
He understands that it's a surgical problem, and they cannot treat it surgically. And medically, there's no further thing we can do. And that, like I said, he was understanding that she already died.
Does he want to make plans to come here at all?
He's coming here. He's going to arrive here around 12:30 in the hospital. He's planning on coming from Chicago at 11:30.
Think she'll arrive till then?
I don't think so, and he knows that.
He does.
Yeah, but I think it might make him feel better if I had talked with
Right,
you.
I'll put a note in the
Okay,
file. Okay,
thank you.
Okay, fine.
Mrs. Wenner, this is Rabbi Bard. Can you hear me? Just wink your eyes if you can hear me, okay? Blink your eyes. This is Rabbi Bard. Can you hear me at all? I've come by to say hello. We understand that your son is going to be coming from Chicago. Hopefully he'll be here this morning, later this morning. Okay? And I wanted you to know that I'm here as well. And we're going to be here with you. We won't leave you alone, okay?
Thank you.
Any line 4?
She can't.
Okay, she's dead. 10:53.
She's going to be here for a while.
I mean, basically, it's not just his middle lobe that's down. His lower lobe is completely down, and his middle lobe. So, my general approach in terms of dealing with the family about something like this is that even if they can't hear it, I think it's important to tell them exactly what is going on. And if they don't get it the first time, it's not so bad. I mean, if it's so frightening to them that they can't hear it, then that's okay. I don't think you're going to do them any harm, but I think that it's important to be honest with them and tell them exactly what's going on, because eventually they will start to hear, I think, what's going on. So, I think that probably what I'll say is similar to what I said this morning, that he's got...
It's an interesting challenge, because while you'd be talking to the mother saying this, the daughter will be in the background like this. It's a very bizarre situation. I just went on. I despite what the daughter was signaling, I just kept saying it, but it's unusual.
Well, again, I think that, as we said this morning on rounds, it's a very difficult situation. The mother says she doesn't want to hear anything, and you've got these daughters that are all fighting for, control. But I don't think that reasonably you can exclude her from the decision-making process and something like that.
In a scope of 1 to 10 of your lungs, 10 being good and 1 being bad, you're on a 1. You have really poor breathing.
On the condition I'm in.
Yeah.
I got hit very bad yesterday, the day before yesterday.
Falling. Yeah.
Falling. And I went home, no care, nothing. I went
Yeah.
home, they took me home,
Yeah.
all alone.
Yeah.
I was at
Yeah,
home
but
all
then,
alone.
then it's what happened yesterday that's made you feel bad. I mean, why did you go to Dr. Axelrod's office?
My son took me up there.
Yeah.
They told me to bring him up there.
Yeah. Was that because you were having a hard time breathing?
No,
No. It turns out you were.
he's my official doctor. He's the one that...
Right, I understand that. What I'm asking you is, what did your sons come over and see that you were a little bit worse, and they
brought
said,
me up.
okay,
My son brought me up.
yeah. Did they bring you to Dr. Axelrod's because
I told him to.
you told them to? Because you were feeling bad?
No, he's my doctor. He's
I know. Was it a regular appointment, or were you
Yeah.
feeling? Oh,
Was to be this week.
oh, I see.
But I got hit last week, so he says, bring him up. And then from there, he brought me over here.
So it wasn't like a new thing that you were feeling all of a sudden bad, and you went and called him and said, I need an appointment. You had already, it was already scheduled.
Yeah.
Oh, I didn't know that.
Every 3 months I go and see him.
Yeah,
I lost my wife here,
I know you did.
and I was here in 83
Yeah.
myself.
Do you understand what intubation means?
Yeah.
Do you understand?
Freeze you up.
No, that's not what it means. Intubation means it's an act of putting a tube in your mouth and into your lungs, and we attach it to a machine through tubes, and we help you breathe. Okay? And we wait for your lungs to get better, and then we take you off the machine. As you become better, you're able to breathe better on your own, and the machine does less and less work. Unfortunately, your lungs aren't going to get better. So the act of putting you on the machine is almost a futile effort. The machine is there to help you, and then when you get better, we can take the machine away gradually. What's going to happen if we put you on the machine is that you're not going to get better. This is you. It's sad, and it's frustrating, and it's anger-provoking, but your lungs are about as bad as they can get. You know, it tells us from your breathing test, you know the breathing test? Not the little aerosol thing, but the breathing test on the big machine, and our blood gases that we do. That tells us what you're like. And what your body's telling us is that your lungs don't have much left. They've been working for 81 years, and now they're working overtime.
Went on 83 years.
83.
Well,
I think your decision of saying that you don't want to be intubated, I think that's a good decision for you, but I don't think you understood what intubation
yeah, I
was.
thought it was real. I thought
Yeah.
it was
All right? It's the act of putting that tube into your throat and attaching you to a machine. Now, if anything should happen the only reason we would do that is if you got worse than you were. Remember how bad you felt yesterday?
Yeah.
If you got worse than you were yesterday, worse, if you can imagine feeling worse, we'd think about it very seriously. And if we waited too long or things got even worse, your heart might stop. Because without the oxygen in your heart doesn't go. You know that. Without oxygen in your heart doesn't go. If your heart doesn't go, your brain doesn't go. And those are the kind of things that we have to think about. Things to start your heart. But if we don't have that tube in, it's not going to really help us much to have your heart going, because your heart still isn't getting the oxygen that it needs. So that's why we talk about the heart, the shocks, and the medicines, and the tube at the same time. One hand washes the other. You know, you can't have one without the other.
That's like the old saying again, we need each other.
Right.
We need each other to survive. You need heart. I have your heart. I should help you.
right?
Uh,
But what I want to do is help you. I want to help you. But I only want to help you in the manner that you want to be helped. I don't want to do too much for you.
That's the kind of thing.
I don't want to do more than you want me to do. I don't want to keep you alive unless you like living.
That's right.
Okay? That's what I want. And
Disease in your body. Disease in your body.
Right.
Your favor.
we're asking you, we're telling you what we know.
Yeah.
We're educating you about we know about your body and asking you to make a decision. Taking how you feel and what we inform you about what's going on with your lungs. I would think it would be wrong to tell you that we would put you on the ventilator and then be able to take you off. Because I don't think that's going to happen. It may, but it probably won't. The history of people like you tells us that it won't be easy, if ever, able to take you off the ventilator. But go ahead.
I have two grandchildren.
I know you.
Two of my oldest ones are
Uh-huh.
here in Chicago. They're being doctors.
Mhm.
A doctor. Chip Torres and Mark Torres.
Mhm.
John's two oldest boys.
Mhm.
We just married his sisters, oldest sister, in
Yeah.
Connecticut, I was from. And they were there. And they said, we'll see you at the Christmas, Grandpa. I said, I hope so.
That's right. That's why I think it's good. I mean, you have to talk about this with your family. It's something you owe them, and they owe you. To listen to you talk about how you feel and how you want the rest of your days to be.
Oh, yeah. I want to do it.
All right. If you do you want any more explanation about what happens?
No.
You know what
I'm going
happens.
to tell the boys that when they come in.
Okay. If they want to speak to anybody, Dr. Jones, Dr. Taylor, and myself, we're all here. So if you need any explanation or if they don't understand something, have them talk to us.
Hospital. You work in the hospital, don't you?
Yeah, I work here. I'll be here till 7. Okay?
Yeah.
All right. Now, it's a hard thing to swallow. You just think about it. Okay? Okay.
Mr. Festo.
Sometimes spontaneously will open and close his eyes,
But not in
but
relation to...
nothing, no response.
We're going to take a look in your eyes.
It's not an uncommon concern. I mean, you see that.
And they rove back and forth sometimes, which just indicates
It's responsive, small
massive damage.
Small, yeah, it's sluggish but responsive, but he doesn't have corneals.
So he has brainstem.
He said
Yeah,
corneals
this
at times.
is, yeah, well, which is why I say that.
Right.
Due to Alzheimer's.
I'm going to turn your head there, Mr. Festo. See how they move back to midline?
Yeah.
And they turn. That's doll's eyes.
That's positive doll's eyes.
Positive doll's eyes, too.
Right.
Pollitt? Good morning. Mrs. Pollitt? How are you doing, dear?
Spontaneous bleed. Corticate type posturing.
Good morning. Can you open your eyes and look at us? Is that better? For this world. Mrs. Pollitt, we're going to take a listen to your heart and your lungs.
Sense I got from the family was that they appreciate the fact that he is not going to survive. They want us to continue to support him aggressively, but they want to make sure that he's comfortable.
Right.
So I think you have to temper whatever you do with that. I think that a lot of what we're doing now is more giving them another day or two to cope with what's happening.
Right. What they said when they left yesterday was please try to save him, but don't let him suffer. And that's why I said, reversibility is is, I think, the only indication for any pressers.
They and we don't really feel any of this is reversible, but they're not quite ready to say that.
They also, just to pass on this information, do not want to be called if he deteriorates in any way. They can't handle that anymore. They only want to be called if he dies.
I spoke to him when he was alerting with it in case we were speaking about it.
He's alerting with it now, and I think that he still wants to go ahead. It's just that I just had the feeling we're not.
Doing him a favor.
Well, I mean, we can keep doing this, but I think that we'll probably be able to drag it on for a couple weeks, probably. But that's all right. I mean, I think if that's what he wants, I don't have any problem with it. It's just that I want to be sure that that's what we want, and I also want to be sure that we get the cardiologist here and make sure that we really are doing everything that we can do.
Well, a whole slew of them know him from recent admission, so
great. So
anyone in the crew would be fine.
10 of them up here to tell us we've done everything.
Exactly.
All right, thanks, Bill.
MICU? Yes, this is her.
How you doing?
Oh, good.
No, this is Suzanne. Mary's coming along.
For this situation, this is very bad.
We're killing him, I think. We're kidding ourselves when we think that these meds are helping him. The guy would be just the same if he wasn't on them.
He would be just the same.
He really would. No. I'm not saying he is.
And it'd be better to get him out of the hospital. Get him out of the
We are not
intensive care
doing
unit.
one. I bet if we put a swan in and checked all his numbers, they'd be exactly the same as when they were
a week ago
without anything.
Yeah, I agree.
It's really funny, I haven't been here
Mm-hmm.
since we put the swan in Friday night, and it's unbelievable because you have such an objective. I mean, you come here and you say, "What has been done?" We come full circle with this guy.
Mm-hmm.
Like I mean, when we put the swan in, it was because he had a fever, and it's like nobody even mentioned anything about the fever. What happened to that?
Fever's gone, not an issue.
No sepsis.
The thing is, he's one of these guys with end-stage cardiomyopathy. You can't do anything. You might as well get him out of the ICU. Take him off all these drips before something's going to happen.
I think we're being really mean.
Did he keep going to failure at home?
Well, he had only been home for 2 weeks, Mary. He had been at the Braintree rehab for like most of the summer after all his heart surgery. And so he had like a little bit of dietary indiscretion at home. He had a field day with Kentucky Fried Chicken and that kind of stuff. Poor guy. He's very brittle. I bet he wishes he'd never done that.
Had the chicken. Yeah.
Can we take a listen to your heart and your lungs?
Sure.
Good.
Okay.
Just under this, if you listen to your heart first, and then we'll sit you up.
Yeah. Scratch my back a little bit a bit.
Want us to scratch your back? Where do you itch?
Just the up top there.
Right there?
In between. In between, over a little more. That's it, yeah.
Good.
Oh, that's wonderful. Get the doctor to scratch my back the first thing in the morning.
I say. Let's just take a listen here.
All right.
What's the long-term goal here?
Well, I mean, what do you mean? The long-term goal is he might get better, he might get worse, he might stay the same. He sounds like he's slowly getting worse.
I think
So,
seems to me.
yeah.
That's my opinion too. I just wondered, how long he's going to stay on all these drips and everything. Because it seems like he has end-stage heart disease.
Lauren. I mean, what I do is I stop all this stuff and give him morphine at this point.
I don't think it would be any different to stop this stuff.
I don't think he would. I hate to say it, but I don't think he would either. I don't think we've done anything for him.
We haven't.
But I think he's dying. I think he's dying. I mean, I think it's, I don't know how long it's going to take, but It could take 2 days or it could take 2 weeks, but we have nothing to offer.
I mean, I think at this point, the best thing we can do is be as aggressive as we can be about getting him out of here because, let's face it, the man was home for 2 weeks in the last 6 months.
We're not going to get him out of here. He's not getting out of here.
Let's get him so that he's not hooked up to all this stuff. And he can...
I think what I probably would have done in the middle of the night last night with the chest pain is I just would have pushed the morphine until the pain went away and his pressure would have bottomed out and it would have been. But look, we've done everything humanly possible that you can do here. We've given him every kind of
drug known.
and we know that this, and we know that I mean, we take a step backwards every day. A guy hasn't had a diuresis over the past week. So, I mean, I think we ought to talk to Bill Taylor, and maybe talk to Mr. Gavin about some of the stuff. And I mean, I really don't think things are going to change. I mean, I think if we give him the morphine, and it may be that he wants us to keep going. Maybe that he wants to sort of keep up with us, because he certainly did before. I mean, he had this near-death experience in the SICU where he was in there for 2 months, and he finally got home for a week and a half, but after his cabbage. So he may, want to keep going.
When I talked to him in the past, he does.
Yeah.
So, I mean, I have a hard time just stopping everything right now.
Well,
what I would do is talk to him, and the next time he has that amount of chest pain, just stop everything, assuming that the dobutamine and the Amronone is making it worse. And
give him morphine for the pain. Yeah.
Once you've talked to him about it first. Yeah.
Yeah, no, we got to talk to him.
But it's also, there's a medical decision to be made.
Exactly.
I mean, someone can't live forever on Amronone, dopamine, dobutamine, etc. So you can sort of, even if he still wants everything done, you can't live forever on those drugs.
Forever at this point.
You can sort of start withdrawing one, and then another, and see what difference, if any, it makes. It probably is not going to make that much difference.
That's the irony of it all, is that, he's at the point where the extra fluid that we give him from these medicines counteracts the effects of any of the medicines. So you could make a medical argument that he's better off on, none of them than, just get a daily Lasix dose. Well, I think we got to talk to him, and we got to talk to Billy. I mean, his DNR, so it's not I don't think that there's any urgent issues here. I think he knows, I don't know if you looked at him, got to look at him when we walked in the room this morning, but he looked cadaverous.
Mr. Gavin, what happened last night?
Well, I was watching the ball game, and my chest started to give me some pains, and they came in, and I don't know, they gave me all kinds of medicine. And finally, about 2 o'clock, they left me. The pain had left. Now, I don't know whether it was an angina pain or what kind of a pain it was.
Mm-hmm. Can you tell me a little about what it felt like?
Well, it seemed to be centralized more right here in the center here.
Mm-hmm.
But it was quite severe. Matter of fact, there was about 4 doctors here.
What was that like for you?
Well, it was like the pain when I first came in the hospital.
You mean when you came in a few months ago?
No.
You mean this
time?
time?
I come in last Tuesday.
Uh-huh.
That's just what it felt like. Last Tuesday's pain. So they left about 2 o'clock, and I never moved the rest of the night. I laid perfectly still. The nurse made me stay still the rest of the night, and it went away then.
Are you having any of it now?
No. I'm doing pretty good now.
Good.
There's no pain whatsoever.
Mr. Gavin, what's your sense of what's going on?
I really don't know. Nobody tells you too much.
Uh-huh.
You know what I mean?
I sure do. And there's a lot of action around here all the time.
Yes, yes.
I suspect you have your own sense of it, though. Would you be comfortable letting me hear a little of that?
I wouldn't mind. I would like to hear.
You'd like to hear from me?
From you or somebody.
Yeah. Do you have a sense of it yourself in terms of what your understanding is of what's happening?
Well, from what the doctors tell me, now and then, I'm on a borderline. I could pass away or I could survive. They've never told me directly one way or another.
Well, part of that, I think, is because we don't know.
Well, it could be. That's right.
Yeah. You know, we have all these sophisticated machines and equipment and everything.
Yeah.
And we can make our educated guesses, but ultimately, we don't know.
Yeah.
One thing we do know over the last few months with what you've been through, with the heart attacks that you've had and the damage that your heart has suffered, and with the surgery that you had and the complications after that, that the result of all that is to put you on this, what you described as the borderline. And with episodes like the one that brought you into the hospital and ones like the one that happened last night, it makes us concerned about the possibilities for recovery. And we're not sure, as you said, how it's going to go.
Yeah.
You've given us some directions about how you want things handled. You know, initially when we spoke in the emergency room,
yes,
you told me, as you had before, that you wanted everything done that possibly could be. And then when we spoke a few days later, you reconsidered that and spoke with your wife and your family and so on. And you gave me a different set of directions, that you didn't want us to do certain things. You didn't want the tube put back in your throat. You didn't want to be put back on those life-supporting machines that you had been on in the past.
That's right, yes. Yes. I've already signed an agreement with a lawyer on that.
So I heard. The so-called living will.
Yes.
Yeah, well, you told me about that, and your wife did too.
I think my wife is on the same thing as me. We both went to this lawyer, and that was one of the questions he asked us about, what do you call it, living?
Yeah, I've heard it called a living will.
Living will, yeah.
You know, that's important, but people are entitled to change their minds. So the most important thing to hear is the instructions that you give now.
Yes, he told me at that time that I could change my mind,
right.
That it was possible.
Yeah. Well, you know, there are very few people who could make as informed a judgment as you can with everything that you've been through. You know firsthand all the things that happen.
That's right.
So there isn't much question that when you make a judgment about what to do, that it's an informed one, because you've been there. It seems, Mr. Gavin, that we're reaching another point of decision now, particularly with what you went through last night and with what you're going through with all these different medications, because it looks like the medications don't seem to be contributing a great deal to be helping your heart to function more efficiently.
Yeah.
It's also clear that you can't stay on medications like this and in this intensive care unit for an indefinite period of time. The clear hope and the plan would be that if we could withdraw some of these, we could see if you're capable of moving from the intensive care unit and doing okay in a regular part of the hospital with a hope toward moving toward discharge.
Otherwise, you've got to experiment a little bit with the medicine.
We shy away from the word experiment because it sounds like we're treating you like a guinea pig.
Yeah.
But I think that we need to see how you could do without having some of these powerful medications running into you all the time. And one of the things to consider is whether the goal is to give you all the medications and see what that can do for the heart, or to look at the whole picture and try to think toward what happens. Can you leave this part of the hospital, the intensive care unit? Can we safely move you to another part of the hospital in the next few days? And can we think about eventually having you leave the hospital if things go well? What are the goals for your treatment? And we have to face the possibility that you brought up about being on the borderline. We would hope that things would go well and that you could be able to leave this part of the hospital and hopefully that you could eventually go home, as you were for a few days before you came back in this time. But we don't know. And in the midst of dealing with all that, we have to have some idea of what the ultimate goal is for what we're doing. And what I heard from you and your wife when we spoke the other day was that your goal was not to necessarily have every available test, medication, and machine, but that we needed to maybe get a little more reasonable about that and devote our attention to something maybe more realistic. One thing that is realistic is your comfort. We can always keep you comfortable, and we're never going to forget about that. Last night, in the midst of your pain, they were walking a tightrope with balancing the different medications and trying to get rid of the pain. We do have medications to get rid of pain, though. And one of the ways that we could decide to go, depending on how it sounds to you, is to make your comfort our number one priority. And to do things for your comfort, even if it may mean withholding some of the medications that we're currently giving you with all these intravenous drips and so on that can only be given here in the intensive care unit. And how you feel about that is really key in determining what to do.
That's kind of expensive too, isn't it?
Yeah, but fortunately we're in a situation where that's not really something that we have to deal with.
Yeah. Is that right? You don't have to deal with that?
No. That doesn't have to enter into the decision making at all.
Yeah.
Is that something that's of concern to you?
Well, naturally it would be, sure.
Yeah. Your situation with
this thing ain't gonna go on forever, you know what I mean?
What do you mean by that, Mr. Gavin?
I don't mean forever. I mean, for any length of, a real length of time. And I'm fortunate enough as it is now to have the Blue Cross and Blue Shield, taking care of these bills. Otherwise, I'd be cleaned out.
Yeah, anybody would be cleaned out with the bill that gets generated.
Yeah. So.
Yeah, but I think, fortunately, that's something that we don't have to take into account right here in making this decision.
Well, that's good then.
Could you share with me what thoughts you're having about all this? I say, could you share with me what thoughts you're having about all this as we talk about
Well, there's different cases in the paper locally, and the people are nothing but vegetables, if you follow what I mean. It kept alive through machines and so forth. And I wouldn't want to be like that.
Right.
In other words, I wouldn't want to not recognize you or my wife or my family. And that's what I consider a vegetable.
Well, the decision that you and your wife gave me a few days ago, that you didn't want the machines and tubes and so on, is a way that we can promise you that we can do everything we can to avoid that.
Yeah.
That situation usually happens when we use all those machines for artificial life
some
support.
People, what was it, that woman that was on the diabetes there, her husband, that case just a couple of years ago.
I know who you mean.
I forget what
Von
their
Bulow.
name. What?
Von Bulow.
Bulow,
Yeah.
You wouldn't want to be like that,
Yeah.
And that's what I'm considering. Because you always pick the worst case first.
Yeah. No, I understand. Unfortunately, those worst cases are pretty unusual.
Yeah.
But it's not that unusual in a hospital like this to have some cases that may not be that extreme, but that are also very difficult, and situations that I think some people wish they hadn't gotten into by the time they're in it. Not only the people, but their families and so on.
Yeah.
So that I think, although it may be difficult, having this kind of conversation ahead of time, when you're capable of having it, will help do everything you can to prevent that kind of situation.
Well, in a case like that, Doctor, it would depend upon the case. You know? Maybe we were too quick in making a decision on something like that, you know? Of course, we made it down in Florida. We drew the will up down in Florida.
Well, one of the things that I mentioned to you a couple days ago when you gave me your decision then is that these things can always be changed.
Yeah, oh, I know that.
And as you think about it, as you talk to your wife and your kids, what you said a couple days ago doesn't have to be what you say today.
Yeah.
And whatever instructions you give to me and the rest of us here are the ones we'll follow.
Yeah. In other words, do I have to give you a decision today?
Not necessarily.
No.
But I think that we need to continue this conversation because the current situation with all these powerful medications that can only be given here in the intensive care unit is not something that can go on and on and on. And I think one of the decisions that we're facing is, do we see how you would do on fewer of these medications?
Sure.
And to do that might mean really making a new goal for your treatment. And the goal might be that we're going to try to have you on as few medications as possible so that we can think toward getting you out of the intensive care unit. And we're going to maximize your comfort above all else. And if we do that, we have to understand that we're taking a risk because it's possible that some of these medications may be doing something to improve the functioning of your heart and that without them it may be more dangerous. And you talked about being in that borderline situation where we weren't sure whether you were going to survive or not. It's possible that withdrawing some of the medications could jeopardize your survival. It's not something, it's not a step to think about lightly.
I really don't know what to tell you right here and offhand now.
In the past when we've talked about things like this, you've wanted to talk it over with your wife and have us talk together.
Oh, yeah, because it's a big decision to make.
Yeah. She's going to be in a little bit later. Would you prefer to have me come back and we can talk when she's here?
It'd be beautiful.
All righty, let's do that.
Because maybe what she can't think of, I can.
Yeah.
Or I can't think of, she can.
Yep, I know what
Which
you're
is mostly the...
I think it works both ways, Mr. Gavin. All right, well, I asked her to give me a call when she comes in, so I'll come back and we'll all talk together.
Okay.
All righty, good. It's good to see you. All righty, I'll be back later to see you.
Okay.
I mean, the issue is how intensively should he be involved in the decision-making? And if something's a medical issue, like he's not responding well to the inotropic meds that he's on, isn't it a medical judgment that they're not working with?
And should it be presented to him that way? This is what's happened. You've been on these meds for such and such number of days, and they're not working. And I think we need to talk about. I mean, I don't need to tell you how to present it to a patient, but there's a fine line about where his responsibility ends and our responsibility becomes more.
And even in this case, it can be presented to him that it's making him worse because it's giving him
It certainly is.
which the angina is going to worsen his heart function and cause him pain, worsen his heart function, make him more pulmonary edema.
I think just by virtue of the fact that the amount of IV fluid that he's getting with all these different drugs is making him worse. I mean, if he weren't getting all of this IV fluid, I think that we would be able to stay on top of his diuresis a little bit better than we are.
I don't think there's any question. He doesn't have to participate in the medical judgment about how we're going to minimize his angina and maximize his cardiac output. But it is a fundamental reorganization or reorientation of what we're doing if we say that comfort above all else is the criterion by which we judge everything. And I think it would be fair to have him and his wife involved in it. 'Cause, you know, he would have been treated differently last night if that had been the goal. And he could conceivably be treated differently today if that's the change that he will make, I think.
Sure. So he is at this point.
He wants to mull over what we just talked about, which was this sort of stuff, and he wants to wait till his wife comes in and we'll talk some more a little later. And I actually spoke to her a few minutes ago, and she said she's coming in soon, so pursue it then.
So as it stands now, we'll just continue everything. Okay.
Well, not necessarily.
Start taking off some of the inotropes.
Yeah, I think that, you know...
Do you think that's reasonable
the
to
view
do?
is from everybody that they're not doing any good, that they're potentially harmful. And we ought to move... I don't think... I mean, as you said, he doesn't need to make that medical judgment.
Sure.
But in the meantime, we'll treat him.
Right.
Focused on his cardiac output and his ischemia.
Until maybe he comes to terms with the fact that comfort is the way to go, I guess we could put him to back where he was.
Yeah, I think so.
I wouldn't go above this.
Yeah, no, absolutely. And he said that. He doesn't want to be intubated. He doesn't want to be back on a respirator. He doesn't want to be reconsidered for surgery. So that all that helps in terms of the degree of invasiveness that we're going to subject him to. All righty. To be continued.
Okay.
Dr. Morgan, answering page on line 5. Dr. Morgan on line 5.
She can have that. She can order answer page.
X-ray room 7. And as you want,
I'm going to give you a little more, John, okay?
All right.
Give me some. We'll wait a few minutes, and I'll give you some more until you're feeling a little better, okay? A lot better.
Mr. Gavin, it's going to be a few minutes for that medication to take effect and for you to feel some of the pain relief. I'm going to step out and talk to your wife for a couple of minutes and then come back in.
All
Okay?
right.
Hopefully you'll be feeling better soon.
Okay.
None of this is good news with all this going on. You know, last night was more bad news with the long episode of pain he had then. It looks like all the medication that he's getting is really doing very little to improve things.
He's got that shot of morphine. You don't want to fall asleep. He seems to be frightened.
Well, also, I think that... What's your sense of things, Mrs. Gavin?
Oh, I don't know. I've been just hoping that something would break and everything would be fine. It don't seem to be today.
No, it doesn't seem to be.
Yesterday I thought I had a little hope. But today again it don't seem to be any better.
I share some of that. It is discouraging. You know, there's always reason to hope. We never can predict the future for sure, but it's looking worse and worse as more of this is going on. I'm coming to the opinion, and I think the doctors here are sharing it with me, that a lot of the medications we're giving him are really not accomplishing much in terms of improving the functioning of his heart. And I think that if he is going to be able to manage, he's going to have to manage without those medications, since those can only be given here in the intensive care unit. My sense, and the sense of the other doctors here, I think, is that the thing that makes sense is for us to withdraw some of those medications and do everything we can for him, especially devoted to his comfort, to You
You don't think that he will come around with it?
I don't know. I think
We're
that
just hoping, we're all hoping.
we're hoping, and we'll see. I mean, he's got a lot of strength. He's fooled us in the past. He's come through things that we never thought he would.
Yes?
But I think more and more of these episodes make it less and less likely that that's going to happen. But I think it's important to realize we don't know for sure.
And I think now he's going downhill.
That's what it looks like.
It's sad because he has his mind. I don't know what to say. Just hope.
We'll do that together.
All right.
When he's feeling a little more comfortable.
No, I'm just staying. I'm just staying. I feel terrible for him. Because this last hour he's been, well, it was good. The cardiologist was right here on the floor when he had that other attack. So it was kind of, you know, they came right in. I know they're doing everything they can, but just don't seem to be enough for him. Well, do you think he'll go to sleep, or shall I stay here?
I think it's good for him to have you nearby. What do you think?
The boys are here too. They're downstairs.
When they come back up, maybe we could talk as well.
All right. I'd like you to talk to them. I really would. I don't know what else to do. Just hope and say a prayer for him. He's gone through an awful lot.
He sure has.
It's going to come to an end, I think, now.
Have you and he talked about that?
No, he didn't say anything today when I came in. I said, were you talking? He says, yeah, I was talking about, Dr. Taylor was talking about keeping me alive on machines, he says.
How do you think it would be for him if you and he talk about the possibilities, including the possibility that he might not make it?
Well, I always feel that he is going to, up to now. What do you think?
Well, I have the sense that it's on both of your minds and that it might be better for both of you if you could share that. But it depends on what you're comfortable with.
Yeah, I don't want to talk about it. I really don't.
Would it
I
be
don't know
something?
whether he would or either.
Would you want me to bring it up with you there and see if he wants to talk about it with us all together?
Sure.
Well, let's see
But
once
I don't
he's...
want to bring it up. You know, it's a touchy subject, too.
It sure is.
It's a touchy one. When the boys come up, maybe we can talk.
Okay.
All right.
Let's see if he gets a little more comfortable and we can do that.
Will he be asleep with that morphine?
I don't know.
No. All right. Well, I don't know what else you can do. It's up to you.
You know, you're doing a lot too by being there with him. I'm going to go back in.
All right.
Coordinator to call me when your sons come back, and I'll come back and we'll talk.
Okay, they're only gone down for coffee.
Will you let me know when I'll be back?
All right. I'll be here anyway.
Good. Thanks.
Bye, guys. Bye.
all the medications that we've been giving in this intensive care unit kind of doses have not been improving the functioning of his heart. So that I think, we never can predict the future for sure, but he said it to me this morning. He said he's on the borderline between surviving and not. And each one of these episodes that he has, I think, makes it a little less likely that he's going to survive it. He's a very strong man, though.
And he's been through a lot.
And he's fooled us in the past, too, when we didn't think he was going to make it. So I think we have to be humble about our ability to predict the future. But one of the things that I wondered, I spoke with Mrs. Gavin about it a few minutes ago, is that sometimes when everybody's aware of these issues about is he going to survive, isn't he, that it might help to take away some of the barriers between you folks, if that's talked about in the open. Different people are different. Some people would rather not do that. Some people would see it as throwing in the towel and giving up, which we're not doing. We don't want to give them the wrong message. But on the other hand, it's on your minds, it's on his mind. And if it would allow you folks to talk about it, I think it would probably be good for people to be able to share the concerns, because I think he might feel that as support. If he knows you're thinking about it and he is, maybe to be able to talk about it together would be something that he'd feel good about. He's more comfortable after the effects of the morphine.
Yeah.
We can tell.
Gosh. I don't know what we would do.
On the life support.
Would that go as far as that?
Well, he's already given us very clear instructions about that he didn't want life support systems in terms of tubes and machines and so on. He doesn't want his heart restarted if it stops. He doesn't want a tube put in to breathe for him if he's unable to breathe on his own. And I think, frankly, that that's a wise decision, because if it reaches that point where his heart does stop, as it has in the past, or if he's unable to breathe, I think the likelihood of him being able to have a meaningful recovery after that is so small.
Next to nothing.
Yeah, and it really would be.
What you're doing now, Doc, as far as reviving, when he's having these pains and everything else.
You just stimulate him enough to get him going again?
We're actually not stimulating. We're giving him morphine. The primary action of that is to relieve his pain.
Mm-hmm.
But there is some reason to think that it also helps his heart to function more effectively. So if we can get some more effect that way, we're delighted to have it. But we're focusing our attention on his comfort. One thing we can do is to prevent him from being uncomfortable. And morphine is the best way when he's having the pain that we can accomplish that. And if it has other benefits, so much the better. But I think our primary goal at this point is to do everything we can to keep him comfortable.
But he did say he didn't want to be on it.
No, he's made it pretty specific that he
numerous occasions he has said this in the past.
And there really wouldn't be much point to it if his condition the way it is.
That's right.
He's made it pretty clear. I
think we all feel pretty much the same way, really.
And he hasn't walked for over a year, and he says, I don't think I'm going to be able to walk anymore. He says, with this heart condition the way it is, I'm not going to be able. He says, I'm just going to be in a chair, and that is it. I said, well, don't feel like that. I says, you're liable to come around and start walking. You never know. He said, I don't think so. He's got to the point where he feels that he isn't going to get up again.
Well, he knows his condition.
And that's why I wanted the boys to talk to you.
When he is more comfortable, do you want to speak with him alone? Would you like me to go in with you?
Yeah. He'll be asleep a while now. But they can page you.
Would you like to wait? How long are you going to be here, Doc?
I'll be around for a little bit.
All right. Would you want to wait until Jack comes in?
Yeah, I think
Why don't we do that?
Yeah. About what time will you be here? Till?
About 6.
Oh, he'll be here.
Oh, he'll be here probably 4:30, 5 o'clock.
So we'll wait around
Why don't we
and
do
we'll
that?
talk to you?
We'll let Dad sleep for a little while.
Okay.
All right?
All right.
And we'll wait for Jack to come. And then
We can talk to him.
Good.
When he comes, would you like us to page you?
It's up to you.
Well, sure. I prefer to have you talk to him also.
Good. Yeah, I'd like to
So
get
he knows the
to him, too.
ramifications. He knows everything. So he knows everything.
I misunderstood. I would like to get to talk with him. Whether you want me to be in the room when you speak with your dad or not,
Sure.
it'll be up to you.
Sure, that's fine. That's fine.
All right. So I'll be around, and you give me a buzz when he arrives.
All right. All right.
All right, thanks, Doc.
Thank you, Doc.
They can't, I mean, I think the problem is just they lose bowel and bladder. They sort of not function all over, so she needs help.
Okay.
Well, that's probably what it is. Probably I don't know. It seems like I talk a little too much, you know?
Yeah, even the exertion from that probably is a
Yeah.
lot.
Yes, that's what he says, am I talking too much that's causing all this exertion? But I don't know.
Wow. It's like an experiment. When my boy Jackie was in last night, after he left, that's when I had the little attack again. And it seemed to, that's what it was. After he went home, he left about 7:30, about 8. And that's when...
Would that exertion do it?
Well, it's hard to say. You have to wonder if it seems to be related. I think it's possible that it's not related, though. It may be that these things just happen, and we look for reasons to try to figure it out. Sometimes we hit on them, and sometimes it's just a coincidence. We don't really know. I guess that's one of the main messages, is how little we end up knowing.
Yeah. Because, let me see. Well, you and Tommy were in around noontime, wasn't it?
Just about noontime, Dad, yeah.
Yeah. And then it seems that...
shortly after that, you had another one.
Shortly after that, yeah. So I don't know.
I don't think they talk that much.
It's hard to pin it down, right?
Yeah, it is.
Really?
I suspect that some of the talking is probably very good for you.
Stretch those vocal cords.
Yeah.
Do some yelling. Because there was a while there you couldn't talk at all, remember? Huh?
So to get some of the positive stuff that comes from having your family here with you.
So you were going to ask him about the machines and everything.
Yeah, I think we've been through that. I understand pretty well, I think, Mr. Gavin, your instructions about what you wish for us to do if things are to get worse. If your heart should stop, if your breathing should stop. You've given pretty clear instructions that you don't want tubes and machines and all the things that you went through a few months ago when you experienced all of that. I don't know that we need to bring it up again beyond that unless you feel that there's something different or that you've changed your mind about things. You know, if you ever do.
Well, no, it's just that I thought once you get pinned down on this thing, you know, with the lawyer that we'd have to go along with it.
That's not true.
But no, Doctor, you've changed my mind on that.
You can always change your mind.
Yeah.
And we'll go by whatever you tell us, even if it's something different today from what it was yesterday, even if it's different from what you thought when you signed that living will with the lawyer. Whatever you tell us is what we'll go by. And you're entitled to change your opinion, change your instructions to us. And whatever you tell us, we'll listen to that and follow your instructions. Have you thought about changing your mind, Mr.
Have you thought
Gavin?
anything?
Have I thought anything?
Have you thought about changing your mind? Or you just said you want Dr. Taylor to do whatever he thinks is best.
Well, no, the way I was explaining it to Dr. Taylor, because I took the most severe cases, you know, the Van Buren and well, there was a couple more there too that were quite severe, you know, that were, but I just as soon go along, pick out the other ones there and go back. We don't have to take the severest ones on.
You feel like you want Dr. Taylor to do what he thinks is best for you.
What you think is best for me, I'll go along with you, Doctor.
Well, I think at this point, Mr. Gavin, given all that you've been through, given the episodes of pain that you had last night and today, and given the failure of the medications that we've used to try to improve the functioning of your heart, that what's best is probably to try to see how you will do without some of these powerful medications that are making some of their own complications. And in the midst of the changes, as we try to see if we can turn down or even turn off some of these powerful medications, to do everything we can above all else to make sure that we keep you comfortable.
Well, that's the main thing.
We don't mean to be putting it all in your hands. You
Well,
know.
it's fair for us to share it, I think.
Okay. But you know Dr. Taylor will do what he can for you. You know Dr. Taylor will do what he can for you.
Oh, I know that. Definitely.
It's a vote of confidence.
Thank you. We've been through a lot together, Mr. Gavin.
Yeah.
It's been a very long haul for you.
Well, you never know.
No,
He might be up and around before you know it.
No, we don't know how to predict the future.
No.
And we talked about that earlier. I talked about that with your family. We've been surprised before. You've come back from situations that nobody ever thought that you could. So we have to be humble about predicting the future. So we talked about before. But as you said to me this morning, you're sort of in a borderline situation now between surviving and not surviving. And I think that your bringing that up is something that we shouldn't run away from. At the same time that we acknowledge that we don't know what's going to happen, and that we point out that you're a man of great strength and that you've fooled us before in terms of your ability to come back from situations that we didn't think it was possible. I think it's important that we acknowledge what all of us are afraid of too, and what we're all thinking of as a possibility. Because sometimes if we don't acknowledge the possibility that you mentioned this morning, not only the one that you might survive and be up and around, but also the possibility that you might not. Sometimes that can be a barrier between people, even between people who love each other a lot. If you're having a thought about what might happen if you don't make it, and your wife's having that thought, sometimes it's too bad if people can't talk to each other about it.
Well, that's true. That's true, yeah. Because, you know, as you say, Doctor, this living will fools a lot of people.
How so?
Especially people that in our category, like, you know what I mean, that we don't know too much about it, really. I know that.
Well, it's interesting for you to say that, Mr. Gavin, because I don't know many people who know more about it than you do with what you've been through. You know firsthand
Well,
what
that's true, yeah.
all those things are like, in a way that most of us never experience until we're in the midst of it. You've already been there.
Yeah.
So you know very much what those different things are.
We'll just hope and pray. Everything shall be fine. We won't have to worry about those things, maybe.
Well, it's just one of them things you might run into along the way, I don't know.
I hope I don't.
I hope you don't too, but I have a sense that the two of you, and actually maybe all of you, have some things to talk about that if you wish to.
Yeah.
And that's up to you. You know, because I have a sense that there are some things on your mind, not only about the hopeful things, because we all have hope, but also some of the concerns we have if what we're hoping for doesn't happen. And one of my hopes is that you folks get a chance to talk about that with each other.
Okay, we will.
And then we'll do what's right. Mr. Gavin, I'm going to go now and leave you with your family together, but I'm going to be back in the morning. And in the meantime, folks here know how to reach me.
Yes.
All right.
Okay? That's good.
Bye-bye now.
That's good. Good to see you.
Do you need anything? I'll be outside, okay? Just call.
Anyway, he's looking good.
So this is it.
Oh yeah.
I mean, we're not, there's
He's DNR. I mean, he sort of understands what the situation is. Why don't you just come right out and say it?
No, I just, you know.
We've talked to him about it, and Bill's talked to him, and he's pretty. I think he understands that. Everything has been done. I think the goal is to see if we can get him out of here and maybe get him home for. I mean, he's been home for. What did he get? 2 weeks. I guess he didn't even get 2 weeks. 2 weeks out of the hospital, in a rehab hospital. He's never been home since he had the operation. So if we could get him home at all, it would be victory.
Is he, he's on Procaine, can we use IV antiarrhythmics, or how DNR is DNR?
Well, yeah, no, I mean, anything pharmacologically you want to play around with is fine.
Okay.
But I mean, I don't think his ectopy has not been a problem.
No.
Power
It was mainly
failure.
diuresis.
Power failure has been the problem.
Okay.
And chest pain.
And chest pain. But he, I think basically what we decided to do is respond to the chest pain with morphine and nitro rather than. And at this point, I wouldn't put him back on IV nitro. I would just, give him morphine and the paste. We're not going to escalate this thing again. Guy's been through enough. But that's not going to be an issue today. I mean, he's looking good. May get him to the floor.
I'll come back and get all that stuff.
Well, my glasses are over there anyways.
Yeah, do you want them to come with you now, or?
No.
Okay.
I should have them with me at all times because I'm as blind as a bat without them.
There are some
Do you
things
want to
no
take
one
your
sees.
applesauce with you?
I do not want that stuff.
No applesauce.
No
Absolutely
apple.
not.
I did not order the applesauce, and whoever took my dinner did not want the applesauce.
I did.
You took my dinner?
No, she wants her applesauce.
I ordered the applesauce.
Oh.
Whoever
Well,
took
you
the
can.
dinner.
Why don't you take the applesauce?
I don't want it. No way. I just thought maybe he would have it. Oh.
I'd love
Sure,
you
I
to
bet,
have it.
I bet when we get down there, he's going to be calling me up on the phone looking for his applesauce. Okay?
Yep. I'm all set. Give me the dishes too.
Can you hold your chart for me?
Yes, put it right in there.
All right.
How's that?
Have I got a handkerchief around here?
Yeah.
Yeah, I threw it in your bag because it kept
Okay.
landing
Yeah.
on the floor.
You don't need it. That's it.
See you later. Are you going to pay?
Same problem that we had with the Wong family, and this person was brain dead.
He's not brain dead,
I know
though.
he
I
isn't,
mean,
but-
legally brain dead, the tube comes out and that's it.
Well, that
But-
wasn't with the Wong family.
No.
The patient was legally brain dead by
Oh,
all
I don't know
criteria,
about
by
him.
all the Harvard criteria, and we kept the patient on a machine, basically
Right.
kept the heart breathing for 3 days until the family could deal with it. And even after 3 days, they couldn't deal with it.
But it's
And when
out
the
of their
tube
hands.
did come out,
It's not their
they
decision.
blamed me. I was the culprit. I killed their mother. Is
They said
what,
that to you?
Not directly to me, but because I was the most visible person. And you know, it's hard. It really is hard when people try to blame it on you because, you know, the inevitable happens. We have no
Right.
control over the fact that their mother is brain dead. And I guess it's all in the way you look at death,
I don't
whether
think
you
they
look at it
understand
legally
that.
or emotionally.
Well, it's a
And
very hard concept, I think, to understand brain dead, and I think that's
it is. And I think
that's where you get
well,
into the problem of providing too much information to families, and
I think
like I said, it's just a difficult
we shouldn't say
concept.
brain dead. What we
Right.
should say is that your family member has passed away, and the only reason you see a heartbeat is because we're artificially keeping the body essentially alive, going, keeping the heartbeat going because of oxygen. Because the longer that we procrastinate, in that particular instance, the longer that we keep the person's heart beating, the more confused the family's going to become. If you tell the family on a Monday that your mother is brain dead, and 3 days later they're still, quote, alive in the bed as far as they're concerned, then obviously they have hope, and they start to question, you know, whether it is in fact true that she is brain dead.
The question is, why do you, just to talk about this and then to get back also to this situation, which you're going to have to live through this weekend. I mean, that's the other piece of this. And what does that feel like to live through this? But, I mean, why do we get into saying that anyway to families? I mean, that's really the issue. Why do we do it?
I think to protect them. I think to make it easier for them, I guess, is kind of the... It's
to make it
difficult...
easier for them or to make it easier
for
for
maybe
us?
for us. It's difficult to say to someone, I mean, maybe it gets into how you really look at death, and, you know, is the person, I mean, you're in there, turning the person from side to side, you're doing AM care, but yet the person is supposedly dead. I mean,
Well, I
it's...
think also to get everyone in agreement that that is in fact the case, that someone's dead is another difficult thing. And my understanding is neurology wanted to correct the sodium, right?
Yeah, and actually...
So then you start getting various...
But that was to supply criteria, though. You know, they wanted to supply the criteria for brain death. You know, not febrile, not hypothermic. And he wanted, evidently there was a case of electrolytes being not in balance.
But even after they were, the family
Yeah,
still
right.
didn't accept it. They wanted a fourth consult.
But don't we tell, in the question, we tell families that because we involve families in the whole decision-making process and the whole plan. And from my experience, they're involved much, much more here than anywhere else I've worked. I'm not sure more than they should, but for sure it's more than most.
In some cases, it's more than they should. We're allowing them to make a decision that is not, that they know nothing about. We're not informing them of what exactly is going on.
Well, I think they are being informed, but it's what they can process. I mean, all the
But we
medical
show-
terminology.
we-
I mean, we went to school 4 years for us to understand this. I had a hard time when I first came here, brain dead. I'm like, yeah, but the heart's beating. And, but wait a minute, but they're really dead? And then when I learned about the Harvard criteria, I even had a hard time, and I'm a nurse, and I'm sure the families have a hard time in a 1 hour conversation with the docs to say, yeah, he's dead, and we're going to take the tube out, and that's that. And but like, wait a minute.
And I can understand that completely. And that night, logically, I could understand all the steps that they were going through. But it's very difficult when you give that much energy to have basically a family member put the blame on you, essentially, to say to you, you know, how could you possibly want to take that tube out? What's your motive here? I mean, he went to the extent of, is your motive that you need a bed in the intensive care unit?
No, they said that.
Yes. I mean,
That's awful.
because they didn't
how
truly believe that. I understand that. They really, truly didn't believe that. The problem was is that they were under so much stress. They didn't know which way to turn. You know, it was like, oh my God, the day has finally come. This is the end. And I was the most, as the nurse, you're the most visible person. You're there consistently throughout the whole evening. I was there. You know, neurologists come and they go. And I was the person that this particular son decided was person that he needed to vent his anger
But
at.
you were also taking care of the patient who was dead but alive. I mean, you were...
And that's hard to do.
Adding to the end, exactly. Exactly. I mean, you somehow add to the confusion when you continue to take care of someone who they understand is dead.
You can understand.
I mean, I think that you're gonna get the heat. You're gonna get a tremendous amount of rage, and you took care of them. They're dead, but they're alive. And now you're going to end their life. I mean, how do you begin?
Right.
I mean, we could talk about it here. It sounds kind of...
Nobody else more logical to put blame on.
Well, it's confusing.
they can see.
It's confusing.
Right.
It is confusing, but I guess the question is that we do tell them that way to give them time.
Right. We were attempting to make it easier on the family by allowing them, we essentially controlled when we let the person go. They came in on a Sunday and they were brain dead on a Sunday, and we manipulated it by adding stuff, pressors. She was on neosynephrine to keep her blood pressure up. Everything was manipulated to keep her going so that the family could get the consults in and could deal with it. Now, did we make it any easier for that family? Not as far as I'm concerned, because when the end finally came for them, it was no easier on the Wednesday than it was if they had dealt with it right then and there. You know, go right in and say that, you know, we have all the criteria. You know, we do a CAT scan, it shows a huge bleed. We do a flow study to the brain that shows absolutely no flow to the brain. We do all the studies that indicate whether the person is brain dead. If it's true on a Sunday, then, I mean, we didn't make it any easier.
Did they do all that one day, but they still wanted a second consult?
Well, they kept adding consults.
In response to the family.
Yeah.
Yeah, you're not going to change the fact by just kind of softening it a bit.
No, it really
You're not going to change it.
For some families that you need to look at a framework. Someone you have to look at the medical assessment, the Massachusetts state law, what the criteria are, and I think professionals have to take a look at their own morals and values before they enter into each individual situation. And you should try and separate yourself a little bit in that respect. And I think the treatment for the family should be social service and more of an emotional support rather than basing their loved ones' destiny, their treatment in the hospital on the family's emotion. I mean, we're focusing on the family's emotion and we're basing the patient's treatment on the family's emotion. And now we're talking about holidays, and I don't think that's the issue.
See, we
And I
give
think
them
it's
too
all
much control. How many times have we talked about, I mean, they go out and ask the family. I mean, a family that doesn't know anything about medicine at all, do you want your family member to be put on pressors if they should need it? Now, I mean, if I was a family member, I would look, my God. And what you're asking them is to tell you to deny their family member something that might keep them going or alive or save them.
See, I think it's
And
I think it's passing the buck about who's going to make the decision. Nobody is comfortable with the decision.
Or whoever's involved, personal feelings of uncomfortable.
I mean, if I was a physician, I would examine my own morals and my values.
I agree. It's a responsibility
That's not the
to have.
case in 100% of the time.
The BI, though, that has everyone zero in on that, because I never saw the kind of involvement with families at other places. So someone
Do you
from
think it's
up
good or
above
bad?
is, giving this philosophy down to everybody that you have to include the family in the decision making. Include them, but not let them make a decision.
I think we need to study that and look at how do families feel who've been through making this decision afterwards, a few months, a few years after. I think a lot of times if they don't have any medical background, we really put way too much responsibility on them.
But the thing is that when a physician presents this to the family, a physician has a very powerful perspective. And I really believe that he can manipulate any family to believe what he wants to do. And it's the art of experience.
It's by his values and what's morally right to him and
his
where
values.
he's comfortable with the whole
Or
issue.
lack of experience.
As
Let's
in
be
our
honest,
case.
it's only once the decision is that this person is probably going to die. Before
Right,
that point,
correct.
they don't go out. I mean,
That's
when it's,
right.
when, that's really when we
Right.
start. That's when we go out and
Because-
say to the family, how do you want us to do it?
Right.
How
Up
should we
until
do
then,
it?
no one has any trouble making decisions.
No, we excuse people from the room. We're involved in something with, with the person that you gave birth to, and we'll see in an hour. I mean, we don't have them in there. But it is when they're dying that we do that, and I think
nobody's comfortable.
And sometimes we're not present. We're not there on the phone when the host's talking to the family. We'd like to put our 2 cents in, but, when it's up to them how they use their choice of words.
But I've been in a
and-
situation where they've talked to the family, what would you like us to do? And the family said, oh, we'd like everything done, but we want him comfortable. So they took that as, oh, he's a full code. So I started talking, it was Cindy Frusi and I said, well, this is a guy a couple years ago. Cindy Frusi and I basically got a DNR status on this guy at 1 o'clock in the morning. I mean, it was just, well, do you realize that if he dies, if he stops breathing, we will shove a tube down his throat, we will press on his chest, put big lines in his neck, etc., etc. Oh, no, we don't want that. I said, well, that's what they're asking you to decide.
Right.
When you say you want everything done, that's everything. So they said, oh, no, we don't want that. We want him comfortable. I said, well, then that's what you have to tell us. You have to tell us that you don't want drastic measures taken, and those are the big drastic measures. Those are things that you don't want to see and that you don't want to see him go through. And I basically said, I forget who it was, I said, come here, please, the family has something to tell you, they don't want this done, okay, we have a DNR order.
Now did you
were there. That was good.
Did you call the family back, Jane? How did that happen?
They were there. They stayed
They
through
were
the night,
standing here. They were
and we
hearing-
put him on a morphine drip, and he got very short. He was a guy with lung cancer or something. And he was at home for 6 months, 8 months, and they had taken care of him, and they realized this was the end.
Yeah.
But he was in the ICU because the decision hadn't been made. He was like this, being intubated, and we basically coordinated. The physicians weren't listening to what the family was saying, and as you spent more time with the family, you got an idea of where they were sitting, and the physicians were busy. So that's the role we play as a true patient advocate situation, patient and family advocate, including the family. What really do you want to happen? You don't come here without dealing with it first.
Right.
I mean, my first month here was I was an emotional wreck because all my patients died. I was like, what was I doing?
Right.
It's very frustrating, but then you solve it and you say, these people are better off dead. They're more at peace, but it also is the way I deal with it.
Right.
My religion, my morals, what I do, how I live my life, my philosophy, da-da-da-da-da.
Right.
And everybody has to do that within themselves.
Right.
And that's why everybody deals with it individually and presents it individually.
Right.
Yeah. So.
Did you